All right, so let's do a quick review on heart blocks. Basically, we're going to talk about third degree heart block. There are three other types of heart blocks. We will not be covering those. So when you are looking at your EKG book, going through your soft chalk lesson, be sure that you are looking at only the strips I've identified for you, because there's other heart blocks and there's actually another entire rhythm in that same chapter in the book. We're going to focus on third degree heart block. So, what is third degree heart block? So, what happens in third degree heart block is we lose the communication between the SA node and the rest of the heart. The atria is doing its own thing, beating its own beats. The ventricles are beating their own beats, and there's no association. So, what you have is you've got P waves all over the place, and none of them make sense. Typically, also in third degree heart block, these rates tend to be pretty slow. So when you look at a strip, the first thing you do is you look at the rate. This strip on the screen has a rate of 40. And then you start looking at P waves. Do I have one P wave for every QRS? So in the first strip, or the first QRS, I have a P wave. That PR looks fairly normal. That looks okay. And then, oh wait, hold on, I got a P wave here. Oh wait, I got a P wave here. It's further away than here, but man, I got two P waves here. And then this is telling us we have a P wave here because this T wave doesn't look the same as the others. And look, I got a P wave here. And oh, wait, now I have a P wave between the QRS and the T wave. That doesn't make any sense. I got a P wave way over here, and I got a P wave here, and I got one here. None of it makes sense. I like to say it's a hot mess. None of it makes sense. There's just no association between P's and QRS's. The other thing that you can do to really tell that it's third degree heart block is the P waves all march out to themselves, which is how we know that there's a P wave here. And the QRSs march out to themselves because the atria are doing their own thing, the ventricles are doing their own thing, and they're not talking to each other. So what's the hemodynamic effect? Well, it depends on the rate. The slower the rate, the more signs and symptoms of decreased cardiac output they're going to have. They can have all the signs of decreased cardiac output, but lightheadedness, dizziness, fainting, syncope are very common because of the slow heart rate and decreased cardiac output. So, treatments for them: pacing, epi, dopamine. This isn't the order. You do whatever is easiest to do first, so we can give them some IV epi. We can do dopamine. Remember, dopamine increases cardiac output by increasing heart rate, which is why dopamine works. And then pacing. And we actually have three kinds of pacing we can do. We can do transcutaneous pacing, which is taking our unit that we tend to call a defibrillator and turning it over to pacing, taking those pads and putting them on the chest. Anterior posterior works better, but we can just do anterior and turning it to pace and pace through their chest wall. It's not great, but it is better than nothing. If we have a post-op heart, they might have epicardial wires, so pacing wires into their heart that we would connect to a temporary pacemaker. Or we could do transvenous pacing, so that would be somebody with a temporary transvenous wire, like a post-heart cath patient that they put a transvenous pacer wire in, and we would hook that up. So we have options for that. All right, let's look at another strip. So let's look at the strip. So the first thing that we look at is it regular? Yes. What's the rate? It's 40. And now we need to look at P waves. So if I look at the first complex, you know that PR doesn't look too bad. But oh wait, there's a P wave here. Oh look, there's a P wave really close. Now there's a P wave here. I don't have anything here. I have a P wave here. Oh look, I got a little notch. I probably have a P wave there. So if I march out my P waves, which means I have a P wave in this QRS, and a P wave here, and this P wave here. My P waves are doing their own things. My R waves march out. I would expect my patient to have signs of decreased cardiac output, dizziness, lightheadedness, syncope, fainting, same as syncope, and the treatments: pacing, dopamine, epi. Okay, so let's talk about pacing, because if I have a pacemaker, whether it's a temporary pacemaker or the patient comes in and has a permanent pacemaker, I need to know what kind of pacing. So we have three kinds of pacing. We have atrial pacing, we have ventricular pacing, or we have AV pacing, which is atrial and ventricular. And the way you determine what kind of pacing you have, you find the pacer spike followed by what kind of waveform. So in this first option, we have a pacer spike followed by a P wave, which is atrial pacing. The second one, this big giant thing here is not a QRS. This is actually a pacer spike followed by a downward deflected wide QRS. This is ventricular or V pacing. They will have wide QRSs. So if I have a spike followed by a P wave, it's A pace. If I have spike followed by a QRS, that's V pace. The way pacemakers work is an X amount of milliseconds go by, and if my SA node doesn't fire, then that pacer will spike, bzz, shock the heart, give it a predetermined number of milliamps, and then I expect to see depolarization, the waveform. So this is atrial. I see a P wave. This is ventricular, so X number of milliseconds go by before I have a QRS. The patient has their QRS, or if they don't, then I get a spike for the QRS. That's V pace. Now, AV pace is spiking before the P wave and the QRS. So it spikes for the SA node, and then that impulse doesn't transmit any further down, and it spikes again for the QRS. So that's AV paced. All permanent pacemakers now are rate dependent, which means they get faster when the patient demands that they have higher rates. Pacers have a set rate. Usually it's somewhere at 70 or 80, and it's important to know the set rate because the patient should not ever have a rate less than the pacemaker. If the pacemaker is set at 80, they should never have a heart rate less than 80, because if they do, that means the pacer's not working. Can they have a heart rate faster? Yes, because that's their own heart having rates faster. So what happens in AV pacing, it's X number of milliseconds go by. If nothing happens, I spike for the P wave. If I don't spike for the QRS, then I get a QRS. Now, when patients are 100% paced, you cannot determine their own intrinsic rhythm because they're 100% paced. Now, if they're having a heart rate faster than their own, faster than their pacemaker, you may see intrinsic beats. You need to see several beats before you can determine what their intrinsic rhythm is, whether it's sinus or atrial fib or atrial flutter and things like that. All right, so let's talk about pacing problems. So the first one is called failure to pace, which means nothing happens. So basically, this is a V pace. We have actually a really small pacer spike here, wide bizarre QRS, which is common for V pace, and then the pacer didn't do anything. And basically, the patient doesn't have a rhythm there. So if that is prolonged, your patient will be DRT. Does not happen very often. Failure to capture and failure to sense are the two that happen more. So failure to capture is the pacemaker going bzzzt to the heart, and I get depolarization. And when you have failure to capture, you get a pacer spike. So the pacer spikes where it's supposed to, and the heart didn't do anything because that is an intrinsic beat. I should have an immediate beat after. That's failure to capture. And what the problem with that is we're going to have decreased cardiac output with that. Now, failure to sense is the pacer spiking in a place it shouldn't. So if you look at this example, I have a V-paced beat. I have an intrinsic beat here, and I have an intrinsic beat there. And then, wait a minute, I have a pacer spike right in the middle of that. Absolutely, I should not be spiking in the middle of two intrinsic beats. So the pacemaker is not seeing or sensing correctly, and it's trying to spike in places it couldn't. The reason this is dangerous is that hit on the T wave, and it could put them in RONT TAC VFib. So I hope that helps you as you study for your heart blocks in pacemakers.